Welcome to the deep dive. Today, we're venturing into a part of the body you probably don't think about much unless it causes trouble.
Mm.
We're talking about the arteries feeding your intestines. The condition is chronic mesenteric ischemia, sometimes called abdominal angina.
Or even intestinal angina, yeah.
Sounds a bit unusual, maybe, but understanding how these blood vessels work and, what happens when they don't can actually give you some pretty surprising insights. Insights into the balancing act our digestive system pulls off every day.
Absolutely. And for this deep dive, we've been digging into Rutherford's vascular surgery and endovascular therapy, the 10th edition specifically. It's quite dense.
It really is. So think of us as your guides today. We're trying to pull out the key information, the essentials from this big resource so you don't have to wade through it all yourself.
Exactly. We want to hit the highlights.
Our mission really is to extract the crucial stuff about CMI. What is it? Why does it happen? How do doctors actually figure it out?
And the treatments available, of course.
Right. We're aiming for those kind of aha moments that make these complex medical topics clearer, maybe more relevant, without getting lost in every single detail.
Sounds good. Let's jump in.
Okay, so let's start at the beginning. What exactly is chronic mesenteric ischemia?
Well, basically, CMI is a condition where the arteries, the ones supplying blood to your intestines, they become narrowed or blocked. And this happens over time, gradually.
Gradually reducing the blood flow.
Exactly. And that slow reduction leads to a pretty specific set of symptoms.
Okay, so what's the main clue? The thing that might make someone think, maybe this is what's going on.
The classic symptom, really, is abdominal pain that starts after eating.
After eating, consistently.
Consistently, yes.
Yeah.
You eat a meal and then, boom, significant pain in your abdomen. And unfortunately, this often leads to what's called food fear.
Food fear.
Yeah, people literally become afraid to eat because they know the pain is coming. It's a powerful connection, actually first clearly described way back in 1918.
Wow, food fear. That really paints a picture of the impact. Now, how common is this? It sounds quite specific.
It is relatively uncommon, yeah. To put some numbers on it, CMI accounts for less than 1 in 100,000 hospital admissions here in the U.S.
Less than 1 in 100,000.
Right. And it makes up less than 2% of all hospital stays for any kind of gastrointestinal problem. So it's rare.
Okay.
But understanding it, like you said, tells you a lot about how vital that gut blood supply is.
Definitely puts it in perspective. So why is that constant blood flow so important? Why do the intestines need so much?
It's absolutely critical. I mean, even when you're fasting, just sitting there, about 20% of the blood your heart pumps out goes straight to the mesenteric arteries feeding the gut.
20%, even at rest.
Yep. But here's where it gets really interesting. After you eat, that demand skyrockets.
Skyrockets. How much we're talking?
Oh, it's a dramatic surge. The blood flow can potentially jump up to maybe 2,000 milliliters per minute. That's a huge increase, and it can last for, say, 3 to 6 hours after you finish eating. This increased flow is called postprandial intestinal hyperemia. Now, it's essential for digestion, absorption, muscle activity, all of it.
Okay, so the narrowed arteries in CMI, they just can't handle that surge, right? That's where the pain comes from.
Exactly right. If those arteries are significantly narrowed, they simply can't deliver enough blood to meet that post-meal demand. You get an imbalance.
An imbalance between supply and demand.
Precisely. The intestines need more oxygen and nutrients than the restricted blood flow can provide.
It sounds a bit like angina. The chest pain when the heart doesn't get enough blood during exercise. Is that a fair comparison?
That's a perfect analogy, actually.
Yeah.
It's often called intestinal angina for that very reason.
Oh, okay.
Just like the heart muscle screams out in pain when it starves of oxygen, the gut does the same thing when it experiences that relative lack of oxygen after eating. And interestingly, because the gut has a pretty good backup system, collateral blood vessels.
Right.
Most people only start getting symptoms when at least 2 of the 3 main mesenteric arteries are significantly blocked.
2 out of 3, typically.
Typically. It's not an absolute rule, though. Some people, especially if the main one, the superior mesenteric artery, is badly affected, might have issues with just one vessel involved.
Got it. So arteries narrow, blood flow gets tight, especially after eating, causes pain. What's usually causing that narrowing in the first place?
The number one culprit responsible for maybe 90% of cases is atherosclerotic disease.
Atherosclerosis, same thing that causes heart attacks and strokes.
Exactly the same process. Plaque builds up inside the arteries and narrows them down. In CMI, this plaque typically forms right where the mesenteric arteries branch off the aorta, the big artery from the heart. usually near the origin, maybe extending a short way in.
Okay, that covers 90%. What about the other 10%? Are there other causes?
Yes, there are less common non-atherosclerotic causes, and these often show up in younger patients, which is interesting.
Wonder patients, like what?
Things like vasculitis, which is inflammation of the blood vessels, conditions like giant cell arteritis, Takayasu disease, polyarteritis nodosa,
Hmm.
also systemic lupus, Berger disease, sometimes spontaneous tears in the artery walls called dissections, fibromuscular dysplasia, neurofibromatosis,
Wow, okay.
artery damage from radiation therapy, a narrowing of the aorta itself called coarctation, even issues with the veins draining the intestines. And surprisingly, certain drugs can do it too, like cocaine or ergot-containing medications.
That's a much wider list than I expected, so it's not just plaque buildup.
Not always, no.
Wait,
Adds a layer of complexity.
okay, so what happens over time if this goes untreated? Is it always just a slow worsening of symptoms?
Not necessarily. It's interesting, actually. If someone has narrowing in just one mesenteric artery and they
Mhm.
have no symptoms, it's often found by chance on a scan for something else.
Yeah.
And usually, it stays benign, doesn't cause problems.
So one narrowed artery might be okay.
Often, yeah. But here's a worrying statistic. Somewhere between 15% and maybe up to 50% of patients who end up with the really bad outcome, bowel gangrene from mesenteric ischemia, which is life-threatening,
Right.
they actually had no prior warning signs of CMI. It looks like a chronic underlying narrowing can suddenly just clot off completely. Acute thrombosis on top of chronic disease.
So it can be a silent threat just waiting? That's concerning.
It really is. And other studies show that some degree of asymptomatic narrowing is actually, well, relatively common in older adults. They might have it show up on imaging but never get the classic CMI symptoms.
So it's there, but doesn't always cause problems.
Right. However, there was one significant study. It followed patients who had severe narrowing or blockage in all three main mesenteric arteries.
All three.
All three. And pretty shocking cavalin. 86% of them went on to develop serious problems, either acute mesenteric ischemia, clear CMI symptoms, or they died.
86%. That really highlights the risk when multiple vessels are involved, even without symptoms initially.
Absolutely. Multivessel disease seems to be a much bigger red flag.
Okay, so who is the typical patient who does develop symptoms? Is there a profile?
Yeah, the typical patient with CMI caused by atherosclerosis is usually in their 60s, and there's a noticeable gender difference. Women are affected about 3 times more often than men.
3 to 1, female to male.
Interesting. And what are those key signs, the things that make a doctor really suspect CMI in that patient?
Well, we keep coming back to that classic triad, right?
Right. Post-meal pain, weight loss, food fear.
Exactly. The pain usually kicks in maybe 10 to 15 minutes after eating, and it can stick around for a long time, sometimes 5 or 6 hours.
5 or 6 hours. Wow. Where's the pain usually felt?
Often described as mid-abdomen, and the character can vary, sometimes sharp and severe, other times more like a dull ache or cramping.
And the weight loss follows directly from that, people changing how they eat. Precisely. They start consciously, or maybe subconsciously, altering their eating habits. Eating less, maybe avoiding certain foods, trying to dodge the pain. And that can lead to significant malnutrition and weight loss over time.
It's an important point, though, that pain without weight loss might not necessarily mean revascularization is the answer, right?
That's a very important nuance, yes. If someone has that post-meal pain, but hasn't lost significant weight unintentionally, fixing the blood flow might not actually resolve their pain. Could be something else going on. A recent review showed over 90% of CMI patients had the pain, but only around 65% had significant weight loss before treatment.
Interesting. And the food fear is that psychological component, just being afraid to trigger the pain by eating.
Exactly. It's a learned response, unfortunately. But it's not always that classic triad.
Oh, what else might show up?
You can see other, maybe less specific symptoms, things like nausea, vomiting, sometimes diarrhea, or even just a vague, sort of persistent abdominal discomfort, or changes in bowel habits that aren't clearly linked to meals.
So it can be subtle sometimes. What about a physical exam? Does that usually show anything?
Often, not much, surprisingly. For chronic ischemia, the physical exam can be remarkably normal. Sometimes the clue is what's not found, almost. The patient describes intense pain, but the doctor's examination doesn't find significant tenderness or other signs to match.
Pain out of proportion to the findings.
Exactly. Though that's maybe more classic for acute mesenteric ischemia, the sudden kind. But you might hear something.
Hear something.
Yeah, sometimes the doctor can listen with a stethoscope and hear an abdominal bruit. That's the sound of turbulent blood flow, like water rushing through a narrow pipe as the blood squeezes through the stenotic artery.
Ah, okay.
Though the doctor needs to be careful to distinguish that from a similar sound caused by something called celiac artery compression, which is a different issue.
Are there other clues in the patient's history? Things that often go along with CMI?
Yes, definitely. Since atherosclerosis is the main cause, you often find those standard cardiovascular risk factors: high blood pressure, high cholesterol, a history of smoking.
Makes sense.
And because atherosclerosis is systemic, it affects arteries everywhere, right? So it's very common for these patients to also have evidence of vascular disease elsewhere.
Yeah.
Coronary artery disease, carotid artery disease in the neck, peripheral artery disease in the legs, or renal artery stenosis affecting the kidneys.
So it's often part of a bigger picture of vascular problems.
Very often, yes. And one last point on presentation, the average time from when symptoms start to when someone actually gets revascularized, gets the blood flow fixed, it can be quite long, around 18 months on average.
18 months. Wow, that suggests diagnosis can be really delayed.
It does. It highlights how tricky it can be to pinpoint CMI, maybe because the symptoms can mimic so many other things.
That leads perfectly into diagnosis. If it's tricky and can mimic other conditions, how do doctors figure it out? What tests are involved?
Well, you're right. The symptoms overlap with a lot of other GI issues, inflammatory conditions, infections, even cancers. So often the first part of the workup is ruling those other things out.
Like endoscopies, maybe CT scans of the abdomen?
Exactly. Things like upper endoscopy, colonoscopy, cross-sectional imaging like CT or MRI to look at the organs themselves. Often, the first real hint that CMI might be the culprit comes when one of these studies incidentally shows narrowing, stenosis, in the mesenteric arteries.
Ah, so it might be found somewhat indirectly at first. Let's talk specific imaging. The outline mentions mesenteric duplex ultrasound first. How does that work for CMI?
Right, duplex ultrasound is often recommended as the first-line screening test. It uses sound waves, to create images of the arteries, and crucially, to measure how fast the blood is flowing through them.
And speed tells you about narrowing.
It does. If the blood has to speed up significantly to get through a section, it suggests there's a narrowing there. A normal result on a duplex ultrasound is actually pretty good at ruling out significant disease, especially in the main superior mesenteric artery, SMA.
But there are limitations.
Definitely. The quality really depends on the skill of the person doing the scan, the sonographer. The patient's body size can make it difficult. Obesity can be a challenge. And bowel gas. Well, bowel gas is the enemy of ultrasound. It can block the view.
Okay. Are there specific numbers doctors look for?
Yes, there are velocity thresholds.
Yeah.
For example, if the peak systolic velocity in the SMA is over 275 centimeters per second, that's highly suggestive of a stenosis greater than 70%.
Wow, that's specific.
Yeah. For the celiac artery, the threshold is a bit lower, around 200 centimeters sec. There are other criteria, too, like looking at the flow speed during the heart's relaxation phase, the end diastolic velocity, using something called the Bowersox criteria, and even looking at the direction of flow in related arteries can give clues. Think of it like speed limits on a highway go way over, and you know there's a bottleneck.
That makes sense. What about CT scans? Multi-detector CT.
Multi-detector CT, or MDCT, often with contrast dye CT angiography, or CTA, is frequently the go-to imaging test for getting a really detailed anatomical map before planning any kind of intervention.
More detail than ultrasound.
Much more anatomical detail, yes.
Yeah.
It shows calcium in the artery walls very clearly, any blood clots, the exact size and shape of the vessels. It's incredibly helpful for planning how to fix the problem, whether it's surgery or an endovascular procedure. And it's also great for checking on grafts or stents after they've been placed.
So if the symptoms are really classic CMI, maybe a CT scan is all you need before treatment.
In many cases, yes. If the clinical picture is strong and the CTA clearly shows significant blockages, that might be enough to proceed to planning revascularization.
And where does MRA, magnetic resonance angiography, fit in?
MRA uses magnets and radio waves, no radiation like CT. It's used a bit less often than CT for CMI diagnosis, but it can sometimes provide useful functional information about blood flow, not just the anatomy.
Yeah.
So it might be helpful in cases where things aren't totally clear from other tests.
Any downsides to MRA?
Well, it might not show as much fine detail if a patient already has stents in place or if there's a lot of calcium in the arteries, because those can create artifacts, interfere with the signal.
Okay. And lastly, contrast arteriography, injecting dye directly. Is that still common for diagnosis?
Less so for just diagnosis these days. It used to be the gold standard, the definitive test.
Right.
But with how good CT and MRI have become, traditional catheter angiography is now mostly used during a planned endovascular intervention. It gives the doctor real-time X-ray images as they're working with wires and stents inside the artery.
So it's become more of an interventional tool?
Primarily, yes.
Hmm.
Or maybe in specific cases where the CT or MRA results weren't clear enough, perhaps due to heavy calcium or existing stents messing up the images.
Got it. So a whole toolkit of imaging options. Once CMI is diagnosed, what are the main goals of treatment? What are we trying to achieve?
The main goals are pretty clear. First, relieve those debilitating symptoms, the pain, the food fear. Second, help the patient regain lost weight and improve their nutritional status. And third, crucially, prevent the progression to acute mesenteric ischemia, which can lead to bowel infarction, dead bowel tissue. That's the catastrophic complication we want to avoid.
Makes sense. Is there any role for just medical therapy, like medications or diet changes alone?
In very specific severe cases, sometimes medical therapy like complete bowel rest, nothing by mouth, and intravenous nutrition might be used as a temporary bridge to stabilize a very sick patient before you can do a procedure to restore blood flow.
A short-term fix.
Exactly. But relying only on nutritional support long-term without actually fixing the blocked arteries, that's generally not recommended because the underlying risk of acute ischemia is still there.
So restoring blood flow revascularization is really the key. When is that definitively recommended?
The Society for Vascular Surgery, the SVS, has guidelines on this. They basically recommend revascularization for essentially all patients who have CMI and are symptomatic.
Symptomatic meaning the weight loss, food fear, diarrhea, post-meal pain.
Correct. If you have the diagnosis and those symptoms, the goal is to revascularize to relieve symptoms, restore weight, and prevent that acute event.
What about people who have the blockages found on scans but don't have symptoms yet? Is preventative treatment done?
That's more controversial. Prophylactic revascularization in asymptomatic patients is still debated. However, some studies, like the one we mentioned, with the high rate of problems in triple vessel disease,
The 86% one.
right, based on findings like that, it might be considered for patients with severe narrowing or blockage in all three main vessels, especially if maybe they have poor access to ongoing medical care, making close monitoring difficult.
So for most asymptomatic patients, it's more watchful waiting?
Generally, yes, close monitoring for any symptoms developing, but with a low threshold to intervene if GI issues do pop up. There's one other scenario. If a patient with severe asymptomatic three-vessel disease needs aortic surgery for another reason anyway.
Like an aneurysm repair.
Exactly. Then it's usually recommended to address the mesenteric arteries at the same time prophylactically.
Okay. So revascularization is key. You mentioned two main ways to do that, open surgery and endovascular. Can you elaborate on those?
Yes, those are the two main paths. And interestingly, the number of mesenteric revascularizations has gone up quite a bit over the last couple of decades.
Why is that?
Probably a combination of better imaging, finding more cases, and importantly, the development of less invasive endovascular techniques. Stenting, basically.
So stenting is more common now.
For patients with suitable anatomy, yes. Primary stenting, placing a stent as the first treatment, has become the most frequent initial approach. It probably accounts for well over 80% of cases now where the blockage looks amenable to it.
And open surgery, when is that used?
Open surgical bypass is generally reserved for patients where the endovascular approach failed or maybe isn't likely to work well because the blockages are too complex, too long, too calcified. Or sometimes in lower-risk patients who might want the potentially more durable option up front.
So it's kind of a trade-off, less invasive now versus potentially longer lasting later.
That's often how it's viewed, yes.
Mm-hmm.
Less invasive initial approach with maybe a higher chance of needing repeat procedures down the line versus a bigger operation up front that might hold up longer.
Let's talk about that endovascular path first. Angioplasty and stenting. What makes a blockage suitable for this?
The ideal target for angioplasty and stenting is usually a relatively short focal area of narrowing or even complete blockage, preferably without massive amounts of hard calcium or extensive blood clot. The main target is usually the SMA, the superior mesenteric artery.
Can the other arteries be stented too?
Yes, the celiac and the inferior mesenteric artery, IMA, can also be treated this way. Although stenting the celiac artery alone sometimes has a higher rate of re-narrowing, especially if there's also external compression from something called a median arcuate ligament. That might require surgery to release the ligament first or as well.
Okay. And what makes endovascular harder or maybe less ideal?
Things that make it technically tougher include really hard eccentric calcium plaque that's off to one side, blockages right at the origin, flush with the aorta, those osseous lesions, longer stretches of disease, very small arteries downstream from the blockage, or multiple narrowings in different branches.
So these factors don't rule it out, but make it trickier.
Exactly. Success rates might be a bit lower. Risk of complications like tiny bits breaking off and going downstream, distal embolization might be higher. Risk of tearing the artery, dissection also increases. And the chance of it narrowing down again over time might be greater.
So the SVS guidelines might suggest open surgery for lower risk patients if the anatomy looks bad for stenting?
Correct. If the patient is a reasonably good candidate for open surgery and the blockage anatomy isn't ideal for stenting, open bypass might be recommended. It's also the go-to if a prior endovascular attempt failed, or if a stent re-narrows, or if the CMI is from one of those non-atherosclerotic causes.
Open surgery often involves a bypass graft, right? A detour.
Yes, creating a new pathway for blood flow around the blockage,
Yeah.
using either a synthetic tube or sometimes a vein from the patient.
Okay. Before any of these big procedures, endo or open, the patient needs a thorough checkup, right? What does that involve?
Absolutely crucial. The pre-op evaluation looks at the patient's overall risk for the procedure. Are they fit enough for surgery or intervention? It assesses their nutritional status. Are they malnourished? And it looks closely at that mesenteric artery anatomy we just discussed because that heavily influences the choice of procedure.
It's not without risk, either way.
Definitely not. So patients get a comprehensive medical workup. We want to identify and optimize any cardiovascular risk factors, address nutritional deficits. This often means cardiac stress tests, maybe lung function tests, checking the carotid arteries with ultrasound, sometimes checking leg arteries too.
And optimizing medications.
Very important. Getting them to stop smoking is huge. Starting aspirin, maybe a beta blocker, getting them on a statin for cholesterol, all part of getting them ready.
And timing matters too, you said. Can't delay too long.
Right. While the workup is vital, you don't want to delay excessively, particularly if symptoms are getting rapidly worse. If someone's pain suddenly escalates, they often need to come into the hospital, stop eating, get started on blood thinners, and have the procedure done urgently, usually within 24 to 48 hours.
What about things like contrast dye allergies or kidney problems?
Good point. For patients with known contrast allergies or pre-existing kidney disease, you have to take special precautions. Maybe pre-medicate for allergies, ensure good hydration, potentially use less dye or alternative imaging if possible before any procedure involving contrast.
Okay, let's dive deeper into the endovascular approach. You said diagnostic angiography is now mostly for planning the intervention itself. How's that done?
Right. So the access is usually through an artery in the groin, the femoral artery, or sometimes the arm, the brachial artery.
Why the arm sometimes?
For complete blockages, occlusions of the SMA, some doctors prefer the brachial approach because the angle might make it easier to get a wire across the blockage. Sometimes a small cut down is needed on the brachial artery, especially if it's small, to reduce bleeding risk after.
And then what?
Ultrasound is used to guide the needle into the artery. A sheath, a thorough tube, is placed. Then a catheter is threaded up towards the aorta, near where the mesenteric arteries branch off. A little heparin, blood thinner, is given. Then contrast dye is injected while taking X-ray pictures.
Fluoroscopy.
Exactly. Different catheters might be used depending on the access site and the angle of the arteries. You need pictures from different angles to see the blockages clearly where they are, how bad, how long. You also look at the aorta and other nearby arteries like the renal and iliacs.
Do they ever measure pressure?
Sometimes, yeah. If a narrowing looks borderline on the pictures, they can pass a special wire across it to measure the pressure drop. If there's a big drop, it confirms the narrowing is hemodynamically significant, meaning it's actually impeding flow.
Okay, so if they find a blockage suitable for fixing, then comes the angioplasty and stenting part. Walk us through that.
The main goal here is to restore good, straight-line flow into at least one main mesenteric artery. Usually the SMA is the priority. Now, just using a balloon, angioplasty alone, especially for those blockages right at the origin, the osteolesions,
Yeah.
it has a high rate of recoil. The artery just springs back. So routine stenting is pretty much recommended for those osteolesions.
Stenting is standard there.
Generally, yes. Again, access can be femoral or brachial, maybe brachial preferred for tricky SMA origins or complete blockages. A very thin guide wire is carefully steered across the blockage.
Got to be careful where that wire goes.
Absolutely critical. You need the tip to be in the main SMA trunk beyond the lesion, not down a small side branch where you could cause damage. Sometimes, especially for long lesions, calcified ones, or if there's clot suspected, they might deploy a temporary filter downstream.
A filter to
Yeah.
catch debris.
Exactly. To catch any bits of plaque or clot that might break loose during the ballooning or stenting. Then a stent mounted on a balloon is positioned across the blockage. These are usually 5 to 8 millimeters wide.
And they inflate the balloon.
Inflate the balloon, which expands the stent and presses it against the artery wall. The stent ideally should stick out just a tiny bit into the aorta. If the artery is very twisty, maybe a self-expanding stent is used instead. And lately, there's more use of covered stents.
Covered stents, what are those?
They have a fabric or synthetic covering over the metal mesh. Early data suggests they might stay open longer, have better long-term patency than bare metal stents in some situations.
Interesting. What if the artery is completely blocked, not just narrowed? Can you still do this?
Often, yes, it's still possible to try and recanalize or reopen a complete blockage endovascularly, but it's definitely harder. You usually need stiffer support systems, longer sheaths, special guide catheters to give you enough push to get the wire through the occlusion.
And brachial access is often preferred.
It can be, yes, especially for SMA occlusions, as the angle from the groin can make it very difficult. Sometimes you even need to pass a wire all the way from the arm down to the leg, creating a through-and-through wire for maximum support.
Wow.
And the absolute key when crossing an occlusion is trying to stay in the true lumen, the original channel of the artery, and avoid digging into the plaque into the artery wall, which creates a dissection. Once you're across, you confirm the wire position, then proceed with ballooning and stenting.
Are there other fancy techniques used sometimes?
Occasionally, in selected cases, maybe. If there's fresh clot suspected, maybe a tiny dose of clot-busting drug like TPA directly to the artery before stenting. For super hard calcified lesions, maybe atherectomy, using a device to physically remove some calcium. But these aren't routine in mesenteric arteries like they might be elsewhere.
Okay. Endovascular is less invasive, but still has risks. What are the main potential complications?
The big ones include heart problems, like a heart attack, bleeding in the GI tract, and paradoxically, causing more bowel ischemia.
How does that happen?
If small bits of plaque or clot break off during the procedure embolization and travel downstream, blocking smaller vessels. This can happen in a fair number of cases if protection filters aren't used, especially in certain lesion types. Other risks include problems at the access site, bleeding, bruising, infection, kidney injury from the contrast eye, and just general surgical risks.
And after the procedure, what's the recovery and follow-up like?
Usually an overnight stay in the hospital for observation.
Well,
Any worsening belly pain after the procedure is a big red flag, needs checking out immediately. Most people can start eating again fairly quickly.
medications.
Definitely. Aspirin is usually started beforehand and continued lifelong. Often another antiplatelet drug, like clopidogrel, is added for at least a month, maybe longer, especially if covered stent was used.
And monitoring?
Yep. Usually duplex ultrasound before leaving the hospital is a baseline. Then regular follow-up with the vascular specialist and repeat ultrasounds maybe every 6 months for the first year. Then annually to make sure the stent stays open.
Okay, that covers the endovascular side well. Let's switch gears to open surgery. When is this the preferred route? And what are the main types of operations?
Right, open surgery. It's generally the choice for patients who aren't great candidates for endo because of complex anatomy, long blockages, multiple branches involved, or if endo failed previously. Or sometimes in specific situations, like needing other abdominal surgery anyway.
And there are different surgical techniques.
Yes, several. The choice depends on the patient's anatomy and their overall surgical risk. A common one, especially for lower-risk patients with multivessel disease, is an antegrade two-vessel bypass.
Antegrade, meaning flowing forward.
Exactly. The graft starts higher up on the aorta, above the celiac artery, and provides flow forward, down to both the celiac and the SMA, usually using a Y-shaped synthetic graft.
What about higher-risk patients?
For them, maybe a retrograde bypass is better. The graft starts lower down, maybe from the aorta below the kidneys or from an iliac artery in the pelvis, and runs backwards up to the SMA, usually just bypassing the one vessel. There's also that hybrid thing, ROMS, retrograde open mesenteric stenting. And less commonly, transaortic endarterectomy, cleaning the plaque out directly from the aorta.
Let's break those down. Antegrade bypass, starting high on the aorta. What's involved there?
It typically uses the aorta above the celiac, or maybe even the lower chest aorta, as the inflow source. This can sometimes give better, more natural flow, and the grafts might be less likely to kink. It requires a bigger incision, maybe midline abdomen, or sometimes combined chest and abdomen. The surgeon exposes the aorta, sews on a synthetic graft, like Docrin or PTFE, tunnels it down, and connects the other end to the mesenteric arteries beyond the blockages, a detour basically.
And retrograde bypass, starting lower down.
Here, the inflow comes from the aorta below the renal arteries, or often from an iliac artery. Using the iliac is often preferred if possible because the surgeon doesn't need to clamp the main aorta, which can reduce risk. The graft, again synthetic, is tunneled up from the inflow site to the SMA, usually, and connected past the blockage. You have to be careful with graft length to avoid kinks. Two-vessel retrograde bypasses are also done sometimes.
You mentioned ROMS again, the hybrid one. Remind us when that's used.
ROMS, retrograde open mesenteric stenting. It's for specific, often complex situations. Maybe someone having emergency open belly surgery for acute ischemia finds a clot, they might stent it retrograde then, or someone with really bad calcium in the arterials, making bypass hard, or maybe after failed endo attempts. The surgeon makes a small cut, exposes the SMA directly, and then feeds a stent backwards from the SMA towards the aorta.
And finally, transaortic endarterectomy, cleaning plaque from inside the aorta.
Yeah, less common now. The surgeon actually opens the aorta and scoops out the plaque, blocking the mesenteric artery origins. It might be considered if endo isn't an option or failed. And maybe if there are other issues like infection nearby, bowel perforation, previous radiation, or big hernias that would make bypass difficult.
During these open surgeries, is there monitoring to check the repair right away?
Yes, intraoperative duplex ultrasound is pretty standard now during open mesenteric surgery. It lets the surgeon see the blood flow through the new bypass graft immediately. They can spot any technical issues, a kink, a tight spot at the connection, and fix it right then and there. Helps prevent early graft failure.
Open surgery is obviously more invasive. What are the potential complications afterwards?
Yeah, complication rates can be significant. Common issues involve the lungs, like pneumonia. The GI tract, especially prolonged ileus where the bowel just doesn't wake up quickly. Heart problems, kidney issues. Malnourished patients are at higher risk for everything.
Ileus sounds common.
It can be. It delays getting back to eating. Wound problems are also a concern, especially in malnourished patients or those with fluid buildup. And while rare, the bypass graft clotting off early is a major emergency, usually meaning a technical problem needs urgent fixing.
And the recovery after open surgery, what's that typically like?
Usually starts in the ICU or a high monitoring unit for a few days. There could be big fluid shifts after surgery, so blood pressure, heart rate, urine output. Pain levels need very close watching to catch any early signs of graft problems or ongoing bowel ischemia.
Getting back to eating.
It's gradual. Start with liquids, slowly advance as the bowel function returns. Some might need temporary tube feeding or IV nutrition, and that food fear. It often takes time and reassurance to overcome even after the surgery works. Plus, ongoing medical therapy for risk factors and follow-up imaging of the graft are crucial long-term.
Okay, we've covered both endo and open pretty thoroughly. How do the outcomes compare overall? Is one clearly better?
Well, the big caveat is there are no large randomized trials directly comparing them head-to-head for CMI. So we rely on observational studies, registries.
And what do they generally show?
Generally, endovascular comes out looking better in the short term, lower immediate complication rates, shorter hospital stays, faster recovery. But the mortality risk, the chance of dying from the procedure, often looks pretty similar between the two approaches in many studies.
But what about long-term?
That's where traditional open bypass has generally shown an advantage. It tends to be more durable. Lower rates of the artery re-narrowing, restenosis, and fewer patients needing repeat procedures down the road, especially compared to stenting with older bare metal stents.
But you mentioned covered stents might be changing that.
Exactly. More recent data on covered stents is encouraging. They seem to have better patency, stay open longer, and might eventually show results closer to open bypass. Still early days for very long-term data, though.
Let's get specific on outcomes. Morbidity and mortality complication rates and death rates.
Reviews suggest endo has an average in-hospital morbidity around 11%. Hospital stay maybe 3 days. Open surgery is higher, maybe 33% morbidity. Hospital stay averages around 14 days.
Big difference in hospital stay.
Yeah. But the 30-day mortality rates, often reported as similar, around 5% for endo, maybe 6% for open overall. Though open surgery mortality can be very low, like 1–2% in good-risk patients at high-volume centers. But it might be higher in community settings.
And symptom relief. Do both work well for that?
Yes, both are generally highly effective at relieving the pain and other symptoms when the diagnosis is correct. Symptom improvement is reported in around 88% after endo, maybe 93% after open surgery. Pretty good for both.
Okay. But the re-narrowing restenosis is the bigger difference long-term.
Historically, yes. Open bypass has shown better long-term freedom from restenosis and reintervention compared to bare metal stenting. As I said, covered stents might be closing that gap. Restenosis after stenting isn't trivial. It happens. Factors linked to it include using bare metal stents, continued smoking, older age, and being female.
And finally, long-term survival. Does the type of procedure affect how long patients live?
Interestingly, not consistently, no. The choice between endo and open doesn't seem to be the main driver of long-term survival for CMI patients.
What is then?
It seems to depend more on other factors, the patient's age and what other health problems they have. Pre-existing heart disease, lung disease, kidney disease, diabetes. Those seem to dictate long-term survival more than the type of mesenteric repair. Studies matching similar patients treated with endo versus open often show similar long-term survival rates.
Our outline also mentioned a chapter algorithm for CMI. What's the gist of that?
Yeah, the algorithm in Rutherford's is basically a flowchart, a visual guide for diagnosis and treatment. It starts with the patient showing up with classic symptoms, post-meal pain, weight loss. Then it walks through the diagnostic steps, usually duplex ultrasound first, then CTA for detailed imaging. Based on those findings, how bad the blockages are, where they are, and considering the patient's overall health, it branches to the treatment options, endo versus open. And importantly, it finishes by emphasizing the need for ongoing follow-up after treatment with checkups and imaging to monitor how things are going.
A roadmap, essentially.
Exactly.
Okay, let's wrap up this really fascinating deep dive. What are the absolute key takeaways you want our listener to hold on to about chronic mesenteric ischemia?
I think the main things are CMI is uncommon, but serious. It has that classic pattern of pain after eating, leading to weight loss. There are good diagnostic tools, especially imaging like duplex ultrasound and CTA. And treatment, whether endovascular or open surgery, is effective for symptom relief. The choice between them really depends on the individual, the specific blockages, and the patient's overall health.
And for you, what was the biggest aha moment in digging through all this?
For me, it's really that stark connection between blood flow and digestion. Realizing how something like food fear isn't just psychological, but has this very real physiological basis in the gut not getting enough blood after meals. It just highlights how interconnected everything in the body is. It's quite profound when you think about it. All right.
That is a great point. Okay, time for our final provocative thought for you, the listener, to chew on. We've talked about these advancements in less invasive endovascular techniques, but also the proven durability often of open surgery. So, looking ahead, what might the future hold for really personalizing CMI treatment? How could new tech, maybe AI analyzing scans or a deeper understanding of individual patient risks and anatomy, further refine how doctors choose the absolute best path for each unique patient-facing CMI?
That's definitely something to think about. Where does that balance shift in the future? And if you do want to explore this more, the references in Rutherford's, especially the SVS guidelines, are excellent resources. They really lay out the current thinking on CMI diagnosis and management, and it just reinforces how crucial vascular health is for, well, everything.
Absolutely. Thanks for joining us on the deep dive.